You could help us by answering those. Good morning again. For those of you who are entering the webinar now, we have some demographic questions. If you could help us by answering those, it helps us understand who we're reaching. We'll get started with the webinar in a few moments. We'll wait just a couple more minutes as people are getting onto the webinar. All right. Hello, everyone, and welcome to this webinar, which will provide an update on the new IDSA HIVMA primary care guidelines. My name is Dr. Stephen Johnson, an infectious disease physician at the University of Colorado School of Medicine. It's my honor to be able to moderate this with our expert, Dr. Melanie Thompson, who is a co-chair of the HIVMA IDSA primary care guidance panel and is with Thacker and Thompson in Atlanta, Georgia. I think many of you know her through her HIV work. In addition, she's a member of the DHHS ART guidelines. Next slide. This is the panel of experts that have put together this recently updated guidance on the primary care for people living with HIV. This webinar is developed through IAS-USA with our content on the web board. These are the members and their affiliations and disclosures. These are the financial relationships that have been reported within the last 2 years for today's presenter and moderator. And regarding CME, the IAS-USA is accredited to provide CME 1.25 AMA Category 1 credits today. And in addition, maintenance of certification points for ABIM, as well as nursing and pharmacy credits. This is the grant support for the IAS-USA. We're thankful to our supporters. There will be poll questions today, and these are the instructions regarding how to do the poll questions. We will submit questions using the Q&A button, and we ask that you not submit questions to chat as our procedure today. With that introduction, it's my pleasure to introduce, here's our demographic questions. We have a lot of physicians and advanced practice providers. That's great. I'd like to introduce Dr. Melanie Thompson, who is our expert speaker from Thacker and Thompson. I've already talked a bit about her, so I'll let her go ahead and get started.
All right, thank you so much. Hardest part of the talk is getting the slides to show up. So Okay, I think we're there. I really want to start by just thanking everybody for taking your precious time to be part of this presentation today. Hope that it is helpful to you in your daily care of people with HIV. Here's my disclosure again, not really relevant to this talk. And, I hope by the completion of this talk, you'll feel comfortable in applying recommendations from the HIVMA IDSA guidance for the primary care of people with HIV, having to do particularly with optimizing care engagement, medication adherence, and viral suppression, but also implementing recommendations about prevention and management of comorbidities and screening and prevention for common STIs. And I'm very happy to announce that the 2024 update is indeed published for the guidance. You can access that at this web address, QR code, as an accepted manuscript. And as such, it's really not very pretty. It's just an accepted typewritten looking page, but we're going to have a pretty typeset PDF for you very soon, putting the finishing touches on that with CID. And hopefully that will be available very, very soon. So let's sort of see where everybody is. Please go ahead and vote whenever you feel comfortable on this pre-test question. Which of the following statements is true? American Indian, Alaska Native men have the highest rates of primary and secondary syphilis in the US. B, PCV15 may be given instead of the polysaccharide vaccine PPSV23 to complete the pneumococcal vaccine series. And then number C, 3 doses of HEPLISAV-B vaccine were superior to 2 doses in prior hepatitis B vaccine non-responders. And D, new U.S. Preventative Services Task Force guidelines recommend stopping cervical PEP screening at age 65 years, including for people with HIV. So take a second, go ahead and vote. And we're going to sort of see where everybody is on these questions before we start the talk. Let's see the answers. Okay, so the majority said A, and C was the second highest vote getter. So let's see what the real answers are as we go through the talk. Now, how about the second pre-test question? Oh, skipped right over it. Okay, so the second pre-test question is about the REPRIEVE study, and particularly which of the following drugs is recommended for people with HIV based on REPRIEVE. Atorvastatin 10 milligrams for a 42-year-old person with a 10-year ASCVD risk of 5% or higher. Rosuvastatin 10 milligrams for a 38-year-old person with a 10-year risk of 15%. C, pitavastatin 4 milligrams for a 55-year-old person with a CD4 count of 225 and a 10-year risk of 4.2%. Or D, simvastatin 20 milligrams for a 60-year-old person with a 10-year ASCVD risk of 8.6%. So go ahead and vote. And let's see the answers. Okay, so there's a bit of a mix here. So we'll be going through these questions, and I might give you a few hints as we go along, if that's not cheating. Or if it is, we'll just don't tell anybody. All right, so why are we doing this? Well, here are most recent data from CDC ending in 2022 about where we are with ending the HIV epidemic. At this point, only 65% of people diagnosed with HIV actually had viral suppression. 54% were able to stay in care. And of course, the goal is to increase this to 95% by 2025. Oops, that's right around the corner, isn't it? That's going to be tough. So, we really have some areas that need improvement in our care system. So our guidance has expanded the section on optimizing care engagement, medication adherence, and viral suppression. And the premise is, if we don't provide a convenient and caring care environment, people just aren't going to come back. And really, why should they? So we always want to provide timely access to care with a patient-centered approach, and offering rapid antiretroviral therapy initiation at entry is a very important component of that, if feasible, and if not feasible, important to work to decrease the barriers to make it feasible. We want to have a welcoming, warm, and stigma-free clinic environment, and that starts at the front door. People first, gender-neutral language is very important, using correct names and pronouns so that we do not misgender or dead name people, because that will be the last time we see some of those people. It's important that we train our staff on anti-racism and cultural humility, and maximizing our workforce diversity so that it mirrors the patient population as much as possible is really important. We know we have real challenges with our workforce, but it is important to keep diversity in mind for so many reasons. And then, as possible, many clinics can offer extended or non-traditional hours, perhaps walk-in care. Most of us can do telehealth. And then alternate care venues, including street medicine, are ways to increase care engagement. And then there are those special times when there are transitions of care. And these include when adolescents transition to adult clinics, the postpartum period, when previously pregnant persons transition back to routine care, times of release from incarceration, and changes in insurance. These are all times when people tend to fall out of care. They need a little extra TLC at this time. Now, there are many evidence-based interventions that can be employed, and I want to just call out a few of these. First of all, a multidisciplinary care model is an important and very strong intervention for implementation. And it's important that a primary clinician be identified, because it is really that relationship with a primary clinician that is important in longitudinal care, important to keep as many of the same faces around for longitudinal care as well, regardless of their role. Now, it's important that we assess barriers to care and adherence, including stigma, domestic violence, and other kinds of violence, and support needs for our patients. And that includes food insecurity, unstable housing, transportation. We all know how these impact the ability to stay in care. There are programs that really can be very important if integrated into care, and those include programs for mental health and substance use, including syringe service programs, and gender-affirming care programs. Also, implementing differentiated service delivery can be very effective, and that's when we deliver the kinds of services by the kind of service provider and the kind of location that is appropriate to the patient's needs. And then I've listed several other kinds of evidence-based interventions here, some as simple as signage in the clinic. And then patient navigation, financial incentives, nutrition assistance, and programs using mobile devices. These are all interventions that have evidence behind them and can improve our care engagement. Now, I want to call out a few advocacy points. As we know, sometimes we may have problems with surgical and dental colleagues who look at a CD4 count or a viral load and say, no, we're not going to do a procedure on that person. So that, of course, is not appropriate care. And we recommend that the HIV specialist get involved in talking with the surgeon or the dentist and the patient, because care shouldn't depend on these numbers alone. The guidance also highlights that people with HIV should be considered as solid organ recipients or donors. Recipients, regardless of the donor HIV status, and solid organ donors to other people with HIV. And finally, I hate to say finally, because there's so many possible advocacy points, but we all need to advocate for repeal of laws that criminalize HIV status. This is very important to destigmatize HIV, and honestly, these laws do not decrease HIV transmission. Okay, so we'll talk a bit about the initial assessment and routine maintenance visits. And by the way, we have 5 great tables, and who doesn't love a good table? So I refer you to those. I think they'll be helpful in your day-to-day care. For the HIV-related history, this is really when we want to begin to develop that rapport with the patient and find out how they are doing with the diagnosis and something about their relationships and partners and support systems. And then a bit about how they were diagnosed. Was it through routine testing? Were they sick when they were diagnosed? Is there a history of opportunistic diseases or hospitalizations? And it's important to ask about CD4 counts, HIV RNA, and antiretroviral therapy in the past and present, but also important to obtain records because, you know, memory really does not serve us very well with these kinds of reports for some patients. Okay, and then moving on to the general history taking. Obviously, we want to know about serious conditions, but I think these days we really want to focus on the metabolic comorbidities and their risk factors, mental health conditions, and co-infections, including viral hepatitis, TB, and sexually transmitted infections. Family history is increasingly important. Thank goodness people are living longer, but it is important to know their family history. Social history should include some of the things that we mentioned before: housing, transportation, food security, employment. And then substance use, we often think of non-prescription drugs and so on, but remember alcohol, a very important drug that is often misused, and then tobacco. Smoking is such an important risk factor for metabolic and malignant disorders. And then I want to talk about sexual history a little bit. I'll offer you this little guide from CDC. You can get it at the QR code there. Some of us don't feel very comfortable taking a sexual history, but remember that most of our patients really appreciate if we're asking about their sexual health. And the CDC defines 5 Ps: partners, practices, protection, and that includes PrEP and PEP, past STIs, and pregnancy intention. So this is a very handy guide if it's not something that you feel very comfortable with doing. And why do we care about STIs? Well, it turns out we have an epidemic, and this epidemic of STIs has been growing over the decade. You can see by this graph, these are data from the recent CDC STI surveillance report, so they're actually more recent than the data in the guidance. You can see that syphilis is at the tip of the iceberg, but the bulk of STIs are chlamydia, with gonorrhea there in between. And the highest rates are in the South and in the West. But if we look at men who have sex with men in a group of STI clinics in 11 different jurisdictions and compare people by HIV status, you can see that People with HIV are disproportionately affected by primary and secondary syphilis, as well as urogenital, and I might say other kinds of gonorrhea in particular. So I think this just intensifies our need to help our people with HIV be adequately screened and treated. So these data look at the rates of cases of primary and secondary syphilis by race and Hispanic ethnicity and sex. And so we're going to talk about disparities some, because I do not think we can end the STI epidemic without focusing on the disparities. And you'll note here that American Indians and Alaska Natives have the highest rate of primary and secondary syphilis. Most of you got that question right, but this is true. And then Black and African American individuals were second in terms of rate. And I want to introduce you to this diagram because it's going to come back several times. This looks at the populations and cases by race and ethnicity. And on the left side, that's labeled percent population, racial and ethnic groups are listed by their proportion of the US population. So this will remain the same through all of the slides that we see. And what you can see here is that African Americans represent 12.6% of the US population, but they represent over 31% of cases of primary and secondary syphilis. And even though they are a smaller proportion of the US population, the American Indian and Alaska Native population has a substantial disparity as well. Now, let's talk about congenital syphilis. It's astounding and terrible that in 2023, we had almost 4,000 cases of congenital syphilis. And here is, again, the same graph. And what you see is that the disparity is most marked in Black and African Americans and Hispanic and Latino individuals, with also disparities that are substantial in the American Indian, Alaska Native populations. So this is 100% preventable and inexcusable. It's a public health failure. And folks, it's really on us to eliminate congenital syphilis. We can do this. Just to show you similar graphs on chlamydia and gonorrhea, you're familiar with these by now, and you can very quickly see that Blacks and African Americans are the most disproportionately affected by chlamydia and gonorrhea. Now, what about screening, treatment, prevention of STIs? Well, we are just terrible at STI screening as healthcare providers. So we should be sure that when we screen for gonorrhea and chlamydia, we are using nucleic acid amplification tests at all sites of sexual contact, so not just urine samples, also testing for syphilis. And how often do we want to do this? Well, obviously on entry to care for everyone. And then at least annually is the recommendation, but the frequency really depends on sexual activities, past STIs, and geographic prevalence. So for many of our patients, we're screening them every 3 to 6 months. Now, in pregnancy, we want to do the screening at the first prenatal visit and at 28 weeks, and for syphilis only at delivery. And if we all did this, we could eliminate congenital syphilis. Also, I want to point out that we should be doing tests of cure after treatment of pharyngeal gonorrhea. Now, for the first time, the guidance is recommending DoxyPEP, doxycycline post-exposure prophylaxis. And DoxyPEP is recommended if there has been an STI in the past year for cisgender men who have sex with cisgender men or transgender women. And I want to point out that there is insufficient data in cisgender women, and therefore shared decision-making is recommended. And this is based on a single study from Kenya that showed no efficacy for DoxyPEP, but it also showed very poor adherence. So there's no reason that this shouldn't work in women biologically, but in actuality, we do not have the data. Now, DoxyPEP is a single 200 milligram dose of doxycycline, usually 2 100 milligram pills, taken as soon as possible after sex or within 72 hours at the longest. And this can be used once, maximum in 24 hours. Now, it has high efficacy against chlamydia and syphilis, but less so for gonorrhea. And this is especially true in areas where there is baseline tetracycline resistance. And antimicrobial resistance, not only for these bugs, but also commensal organisms, is an ongoing concern and is being studied. So it's important to remember to continue to screen regularly while people are on DoxyPEP. And I've given you a link here to the CDC guidelines to give you much more information about that. But DoxyPEP is not 100%, and sometimes people aren't using it after all. But also we're concerned about resistance. So let's switch to immunizations for adults with HIV. We're not going to talk about children and adolescents today for lack of time, but I would refer you to the ACIP guidelines for these groups. And let's start with what's different for people with HIV. Well, what's different is contraindications. So there are some contraindications that apply to all people with HIV. And those include the live attenuated influenza vaccine, the live attenuated smallpox vaccine called ACAM 2000 that is actually being used for Mpox, but not in people with HIV. And then the live attenuated typhoid vaccine is listed in the Yellow Book as being contraindicated in all people with HIV, but the OI guidelines say that it is contraindicated according to CD4 count for those less than 200. And there are other contraindications for those whose CD4 count is below 200 or who have uncontrolled HIV. And the MMR vaccine is one of these. Also varicella, also yellow fever. And remember that people with low CD4 counts or uncontrolled HIV may have a blunted response to any vaccine, and this may improve when their CD4 counts rise. So here is a graphic from the ACIP adult immunization schedule for 2025. And I want to shout out my friend Steve Johnson, who pointed this out to me, that it was actually just published a couple of weeks ago. So hot off the press. We've talked about the contraindicated vaccines. I want to give you a few other notes for people with HIV. For RSV, the ACIP has ditched the shared decision-making language. So RSV vaccine is now recommended for all people 75 years or older, and for people 60 to 74 who have serious diseases, and that would include advanced HIV. And then also there is now a new mRNA vaccine from Moderna. For the Shingrix vaccine, once upon a time, we had CD4 criteria, but now there are no CD4 criteria. So all people with HIV 18 years and older are eligible to get Shingrix vaccine. For the HPV vaccine, just a reminder to give 3 doses. And we do use shared decision-making for people ages 27 to 45. The hepatitis A vaccine is recommended for all people with HIV, as is the meningococcal vaccine ACWY. But we do have a new pentavalent vaccine for meningitis that includes subtype B, And so you can use the ABCWY vaccine if someone is eligible for a meningitis B vaccine plus the ACWY at the same time. It's a lot of alphabet soup. Okay, so now these are the four vaccines groups that we're going to go through in a little more depth. And let's start with HEPLISAV-B. HEPLISAV-B for hepatitis B was studied in people with HIV in ACTG 5379 in two groups, a group with no prior HBV vaccine and a group with vaccine non-response. So looking first at the group without prior vaccination, this was a single-arm open-label study with 74 individuals, pretty good CD4 counts, high levels of viral suppression. And the results were actually really impressive. So after receiving a dose at 0 and 1 month, the results were 98.5% seroprotective response at week 24. Now, the seroprotective response, I remind you, is a level of greater than 10 million international units per mil for hepatitis B surface antibody. So that is a really remarkable level, but after the third dose, 100% had a seroprotective response. And interestingly, 88% of that group had very high levels of over 1,000. So that, we're not sure what that means, but we do have some data about correlation to durability from higher levels. So we will wait and see how this study turns out. Now, the other part of the study was randomized for people who had non-response to prior vaccine. And it looked at 2 doses versus 3 doses of HEPLISAV compared with the recombinant vaccine, which happened to be Engerix-B, 3 doses of that. And you can see that the proportion who achieved a seroprotective response was really impressive for both 2 and 3 doses, so 93 and 99%. Compared to a little over 80% for the recombinant vaccine. And so both 2 and 3 doses were superior to the control vaccine. I think that was a question. And if you look at some of the sub-analyses, which I don't have time to show today, what you see is a hint that there is a higher SPR rate in people with a low CD4 count and with higher viral loads for HEPLISAV versus control, and in some cases, possibly 3 doses rather than 2. But these are very small numbers and not statistically significant. So the recommendation from our guidance panel is that HEPLISAV-B is the preferred vaccine given at 0 and 1 month. And I'll remind us that we don't have enough data to be giving this during pregnancy. Alternate vaccines include the older vaccines, the recombinant vaccines, and just a reminder that these should be given at double strength for both of the recombinant vaccines. You can also use the combination Hep A and Hep B vaccine as well. And I will mention that the OI guidelines just published an update, and they also prefer the HEPLISAV-B vaccine as the initial hepatitis B vaccine. Now, whatever you give, remember to vax and verify. So you want to check those hepatitis B surface antibody titers 1 to 2 months after the last dose. This is very important. And that seroprotective response is going to be higher than 10. Now, what about people who are not responding to vaccination? If they are not immune after a full series of recombinant vaccine, the recommendation is 2 doses of HEPLISAV-B, and that you could consider a 3rd dose at 24 weeks. You saw those numbers. And this is especially a consideration for people with low CD4 counts or uncontrolled viremia. And for the recombinant vaccine, you can revaccinate with 3 doses of double-strength vaccine. And the OI guidelines say that you could consider a 4th double-strength dose, but there are not a lot of data to support that. And again, if the non-response is associated with a low CD4 count and you think the CD4 count is going to rise after antiretroviral therapy, you may want to wait and revaccinate later. Now let's turn to Mpox. Mpox is still with us. The ACIP recommends 2 doses of the Jynneos vaccine for adults who are at risk of Mpox, although there now are some data in adolescents as well. Very important to get 2 doses. So please keep that in mind as you talk about Mpox with your patients. The recommendation is for gay, bisexual, and other men who have sex with men, transgender, non-binary people who in the past 6 months have had an STI, more than 1 sex partner, or sex at a commercial sex venue, or in association with a large public event in an area where Mpox transmission is occurring. This also applies to sexual partners of these persons, and really anybody who anticipates experiencing one of these categories. And I cannot stress strongly enough how we need to prioritize people with HIV for Mpox vaccination and treatment, and we need to use a racial equity approach. In an analysis, it was found that 94% of those who died with Mpox had HIV, and most of them had a CD4 count less than 50. And of all people with Mpox, almost 40% had HIV, and almost 70% were Black. So this is a very important thing to keep in mind, and we must use an equity-based lens in this and really all of our prevention and treatment. Now, one reason that Mpox is still being talked about, in addition to Clade 2, which is ongoing here at a very low level, CDC has released 2 health alert network updates, and one alerts us to the fact that there is Clade 1 in certain areas of Africa. It is endemic in the Democratic Republic of Congo, but also spreading to other countries in Africa. It's transmitted by close contact and including household transmission. The fatality rate for Clade 1A is higher than 1B. And we are seeing travel-associated cases, small numbers, but around the globe, including in the US and Canada. And the WHO declared a public health emergency of international concern about this outbreak. And you can check out this update for the vaccine recommendations. Basically, you don't need to vaccinate everybody who's going to these countries. It really depends on their planned activities within the country. Now, we do have 1 case of Clade 1 Mpox that has been diagnosed and confirmed in the US. That was a travel-associated case, and it was diagnosed in San Mateo County, California. The patient was hospitalized with mild symptoms, but ended up isolating at home, and no tecovirimat was given, and the patient ultimately did fine. We don't know yet whether it was 1A or 1B, but other travel-associated cases have been Clade 1B so far. So if you suspect, based on travel, a Clade 1 Mpox case, please report that to your state and local health departments, but also to the CDC Emergency Operations Center, and you see the phone number here. All right, so let's talk about pneumococcal vaccination. That has been pretty complicated in the past. I think it's getting simpler. We've been talking about a one and done method, which is a single dose of PCV 20 and now perhaps 21 that completes any vaccine series. So in the case of a person with no prior pneumococcal vaccine, or if you're not sure, you can give PCV20 or PCV15. If you give 20, you're done. If you give PCV15, then at least 8 weeks later, you have to give a polysaccharide vaccine, and then you're done. I think there was something about this on a question, as a matter of fact. So you need that polysaccharide vaccine with PCV15. Now, what if people have had PCV13 or the polysaccharide vaccine only? In both cases, at least a year later, you can give a PCV20 and you're done. Or in the case of a polysaccharide vaccine, at least a year later, you can give a PCV15 and also done. Now, a lot of our patients have had both a PCV13 and 1 or 2 doses of the polysaccharide vaccine given before they were age 65. And so at any age, you could give a PCV20 at least 5 years later, and that series is complete. Or after age 65, you could give another polysaccharide vaccine at least 5 years after the last one, and that series is also done. But there is a provision for shared decision-making for people who are 65 years or older, and you may consider giving a PCV20 at least 5 years after any prior immunization series other than PCV15. And this would be based on increased risk for exposure or vulnerability. So what about that PCV21 thing? So PCV21 has 8 new serotypes represented, and the ACIP says that we can use a single dose of PCV21 when PCV is recommended for adults 19 years and older. However, see the red box there on serotype 4? There's a little wrinkle here. So in certain areas of the country, Alaska, Colorado, the Navajo Nation, New Mexico, Oregon, at least 30% of invasive pneumococcal disease was caused by serotype 4. And so this vaccine is missing that serotype. This kind of IPD has been seen in people less than 65 years old who have substance use or who smoke, who have chronic lung disease, or who experience homelessness. And in this sort of situation, really the PCV20 or the combination PCV15 and the polysaccharide provide better coverage for serotype 4. So, you know, we're going to have to watch this down the line. So it's not definitely one that you can substitute in all situations for PCV20. I would say that there is a study of PCV21 ongoing in people with HIV, and so we will have more HIV-specific information down the road. What about COVID? Yes, still around. Remember that people with low CD4 counts can experience worse disease with COVID, up to and including death, more long COVID, rapid viral evolution, and people with HIV may be more likely to get reinfected with COVID than people without HIV. And so really, the vaccination schedules are pretty much the same for people who do not have, as the general population, for those who don't have advanced disease. But for people who do have advanced HIV or who are untreated, if they are not vaccinated at all, we want to give them 3 homologous doses of the 24-25 mRNA vaccine or 2 doses of the updated Novavax vaccine. And then they also get 1 dose of the updated vaccine 2 to 6 months later. If they're incompletely vaxxed, then you want to finish that initial 3-dose mRNA series or a 2-dose Novavax series by using an updated 2024-25 vaccine. And then they also can have an additional dose 2 to 6 months later, and that could be any vaccine. Now, those who've completed their initial series prior to 2024-25 can have 2 doses of the updated vaccine, and those should be given 2 to 6 months apart. And of course, this is an evolving story, so there is a caveat that they may receive additional doses. So I would say stay tuned, and we will see what the next season brings. I do want to mention that there is now pre-exposure prophylaxis for people who are severely immunosuppressed, and that technically includes people with advanced HIV. And that is pemivibart, which is monoclonal antibody that can be given IV every 3 months. And this, in my opinion, is really only for people who are the very most vulnerable. And it is not instead of vaccination. So these folks should be vaccinated as well. Here are some pretty tables from CDC. They're not the most up-to-date tables, however. I've given you the link to these tables. The QR code will take you to the most recent tables, which really just add on that additional dose of the 2024-25 vaccine. But I find these tables very helpful. They're divided up by the manufacturer of the vaccine. What about screening for and prevention of cancer? Well, cancer is the leading cause of death for people with HIV. We have reached that stage. We wouldn't have believed it a number of years ago. But if you look at the trends in cancer incidence, what you see over time is a really striking decrease in AIDS-defining cancers and an increase in non-AIDS-defining cancers. And the most common of these are lung cancer, anal cancer, prostate, a bunch of unknown cancers, or cancers that probably are lower incidence lumped together, and then liver cancer. But screening for many of these, breast, colon, lung, prostate, is really the same as the general population. So you want to follow those general population guidelines. For transgender and gender diverse persons, we want to use the guidelines for the organs and tissues that are present. And remember that the PSA is not reliable if a person is on androgen blockers or has had an orchiectomy. Vaccination against HPV and HBV reduces the risk of cervical, anal, head and neck, and hepatocellular carcinoma. So very important, again, to be sure we adhere to vaccination schedules. And there is no age limit for cervical pap screening, unlike for people without HIV. So I believe there was a question about that. Now, it's important to ask about tobacco use at every visit and encourage stopping. Tobacco, of course, is a risk factor for many kinds of cancer. We should be offering smoking cessation assistance, including pharmacotherapy, as well as behavioral interventions. And at this point, many people's arms just fly up in the air because it's frustrating and we don't really know what to do about tobacco cessation. So I want to give you some resources. These are 2 very helpful resources for people with HIV in terms of tobacco cessation strategies. And I also would call out that our current U.S. Surgeon General has released a new report about disparities in tobacco-related disease and death, and I think this is a very important read. And on the left, I've put the initial report on smoking and health from C. Everett Koop, who many of you may remember as a historical and heroic Surgeon General from the past. We now have International Anal Neoplasia Society consensus guidelines about when to start screening for anal cancer. as well as many other aspects of anal cancer screening and management. So I highly recommend looking at these guidelines. There's a QR code for you. But for people who have HIV and are men who have sex with men or transgender women, we want to begin screening at age 35. For all other people with HIV, as well as men who have sex with men and transgender women who do not have HIV, we want to begin screening at age 45. And so our guidance recommends annual digital rectal exam, whether high-resolution anoscopy is available or not, and then anal PAP if you have access to HRA and treatment. And we have adopted the guidelines that I just showed you. And IDSA has a recommendation to perform HPV testing with cytology and not HPV testing alone. Now, what do you do when you get the results of low-grade or high-grade squamous intraepithelial lesions? Well, for the low-grade lesions or worse, they should be referred for HRA and HPV testing. The high-grade lesions need to be treated, and we learned from the ANCHOR study that we can prevent anal cancer by treating these high-grade lesions. So that is a very important referral to make. And then, of course, we want to refer all anal cancers to surgical oncology for treatment. Now, shifting to metabolic and other non-communicable comorbidities, people with HIV are living longer, but they acquire comorbidities almost 10 years earlier than people without HIV. And here are those data. And if you look at the bottom of this graph, you'll see that people with HIV acquire comorbidities 9.5 years before people without HIV. And then at the top of the graph, you see that the life expectancy gap has really narrowed over the years, and the life expectancy difference is only about 9 years for people between people with HIV compared to people without HIV. But this comorbidity-free survival is really an issue for people with HIV. Now, this is a practice-changing study called REPRIEVE, and it is a large study, almost 8,000 people with HIV who were ages 40 to 75 and at low to intermediate risk for atherosclerotic cardiovascular disease. And people were randomized to pitavastatin or a placebo and followed for about 5 years. And the results, this is a graph from that paper, being on pitavastatin decreased the risk for the first major atherosclerotic cardiovascular event by 35%, which is really a huge, huge impact. Now, another way to look at that is the number of people who are needed to be treated to prevent one major atherosclerotic cardiovascular event. And you can see at that purple line that there's a cut point at about 5%. So only 53 people need to be treated if the ASCVD risk score is between 5 and 10, whereas the numbers go up higher at lower ASCVD risk scores. So this has led to recommendations. These are the recommendations from our panel for statin therapy for the primary prevention of cardiovascular disease in people with HIV, ages 40 to 75, regardless of lipid levels and ASCVD risk. And the first recommendation is that the recommendation is strongest if the 10-year risk is greater than or equal to 5%. So these are people that we really want to get on statins. If less than 5%, there is benefit, but we may consider other risk-enhancing factors. HIV risk-enhancing factors or risk-enhancing factors for the general population. As long as the risk is below 20%, we're going to use a medium intensity statin, and these are the doses for these 3 drugs that are recommended, pitavastatin, atorvastatin, and rosuvastatin. I'll point out that medium intensity dose for atorvastatin is 20 milligrams, not 10 milligrams. And then for people who are under the age of 40, we really just don't have enough evidence to recommend for or against statin therapy for the purpose of prevention of cardiovascular disease. These people were not in the REPRIEVE study, and also the pool cohort equation is not really designed for these people. So some of these people certainly need statins, but we're going to need to individualize our decision by considering the risk-enhancing factors that they may have for the general population and for people with HIV. And I really want to point out this guideline from the HHS Antiretroviral Therapy Guidelines Panel that included representatives from the American College of Cardiology and the American Heart Association and the HIV Medicine Association. And this is a very complete guideline that I think would be really helpful to read in its entirety to help guide decision-making about statins in people with HIV. Now, we have a lot of other recommendations in the guidance for metabolic and other comorbidities, and we don't have time to go through all of those, but the guidance does address monitoring for lipids, glucose, A1C before and after ART initiation, monitoring weight and annual waist circumference. Also, we refer to the workup for non-alcoholic fatty liver disease, screening for osteoporosis, testosterone replacement therapy, and frailty screening on an annual basis for people age 50 or older. Now, I'll give you just a brief 30,000-foot overview of several special population sections that are in our guidance, and we did add a new section on children this year. So starting with people of childbearing potential and addressing prevention of perinatal transmission, it's very important that we ask about the plans and desires that people have regarding pregnancy at the time that they come to care and routinely afterwards. We want to prevent unintended pregnancy. We want to talk about the choices for antiretroviral therapy and also infant feeding. And it's important to initiate antiretrovirals immediately for all pregnant and breast or chest feeding persons in order to prevent perinatal transmission, but also for the parent's health. Infant feeding in the US involves shared decision-making and the use of evidence-based and patient-centered counseling. There have been instances in which child protective services have been called when a person with HIV has chosen to breast or chest feed their infant, and we wanted to call out in particular that this is not an appropriate response to the choice of infant feeding. Now, for children, it's important to start antiretroviral therapy immediately, especially for those who are under a year of age. And this is the group that has the highest risk of rapid disease progression and mortality. And if they are not on therapy, we still need to monitor them every 3 to 4 months and continue to educate and work with the family to overcome whatever barriers there may be to treatment. If there are opportunistic infections, these should be discussed with a pediatric HIV specialist. And for adolescents, we should take an approach that is developmentally guided. Remember that it's important to screen adolescents early for comorbidities because adolescents also have hypertension, hyperlipidemia, and diabetes. And so early screening and management is absolutely crucial for adolescents. And we talked a little bit before about transitions of care. Adolescent transition to adult care is a very hazardous time. It really requires a well-thought approach. And we want to support the capacity for self-care among adolescents. And this includes being able to stay in care and adhere to medication. It includes enhancing medical literacy and also being sure that they get the mental health and substance use engagement that they need when they are transitioning into adult care. For transgender and gender diverse persons, we want to provide care that is gender affirming, non-discriminatory, non-stigmatizing, and culturally sensitive. And I have to say, this is more important now than ever. There is such a huge amount of stigma and fear among these populations right now. So be sure that the intake forms and medical records and other documentation include gender identity options in addition to just sex assigned at birth. And be sure that their chosen name and pronouns are in the medical record in addition to the legal name. We want to offer medically necessary gender-affirming interventions to transgender people in accordance with national guidelines. And if we don't feel comfortable ourselves offering these interventions, then it's important to develop a network and provide referral to another clinician or an endocrinologist who is experienced in transgender care. So I'm going to say thank you for listening. And thank you to the HIV Primary Care Guidance Panel, especially Michael Horberg, my co-chair, and Andrea Weddle, the HIVMA Executive Director, without whom there would be no guidance at all, as well as our reviewers and colleagues, and our support from IDSA. And let's go over our post-test questions. So go ahead and vote. Which of the following statements is true? American Indian, Alaska Native men have the highest rates of primary, secondary syphilis in the US. PCV 15 may be given instead of polysaccharide vaccine PPSV 23 to complete the pneumococcal vaccine series. 3 doses of Heplisav superior to 2 doses in vaccine non-responders. And new USPSTF guidelines recommend stopping cervical pap screening at age 65, including for people with HIV. Okay, let's see where people are after going through the talk. Hey, look at that, 89%. So that is correct, and we're going to go through these answers, if I can find, there we go. So yes, American Indian, Alaska Native men do have the highest rates of primary and secondary syphilis, followed by Black and African Americans. PCV 15 should be given with the polysaccharide vaccine in order to complete the vaccine series. So you could give PCV 20 alone to complete the series, but if you're using PCV 15, you need that polysaccharide vaccine. Both 2 and 3 doses of Heplisav were superior to the control in prior vaccine non-responders. And there is no age threshold for stopping cervical pap screening in people with HIV. Okay, so you all did great on that one. Now let's look at the second question. This is about data from the Reprieve trial and which of the following drugs we would recommend. A is atorvastatin 10 milligrams, 42-year-old with ASCV risk of 5% or higher. B, rosuvastatin 10 milligrams, a 38-year-old with 10-year ASCVD risk of 15%. Pitavastatin 4 milligrams for 55-year-old, CD4 count 225, and 10-year ASCVD risk of 4.2. And simvastatin 20 milligrams for a 60-year-old with a risk of 8.6. Okay, what have you got for me? Let's see. Okay, so most people, 62%, got this right. And let's go over those answers. So C is the correct answer. Pitavastatin 4 milligrams would be recommended. It's a 55-year-old person. That CD4 count of 225 actually is a risk-enhancing factor for HIV and increases the risk of cardiovascular disease. And so even though the risk level is 4.2%, the person has a higher risk for disease, and we would want to treat this person. Moderate intensity dose of atorvastatin is 20 milligrams, not 10 milligrams, so that answer was incorrect. And we don't have any data for people who are younger than 40 years of age, so B also was not correct. And then we really just don't use simvastatin. It's not recommended in any of these guidelines for this purpose. There are a lot of drug-drug interactions, and there are not a lot of data in people with HIV. So option D is incorrect. So one more thing. Those of you who know me know that we cannot end a talk without talking about advocacy. And to end the epidemic of HIV domestically, advocacy really must be a part of our job. And I'm asking you, please, to get involved. Right now, as we sit here today, over $700 million in HIV funding is at risk in Congress. The continuing resolution that has sustained funding will expire on December 20th. I recommend that you call your representative and both of your senators and write a letter. And by the way, you can use this QR code. Thanks to Prep for All, they will help you write a letter to your representatives, encouraging them to save our HIV funding. We always thought that Ryan White and the Epidemic Initiative had been supported in a bipartisan fashion. It appears that that is no longer the case. And so it's really important right now that we reach out to our elected representatives. So please do that. And I also want to encourage you to get involved in the HIV Medicine Association. You can go to HIVMA.org, and there are a lot of opportunities for advocacy, and they will really help you learn to be a good advocate as they helped me. So I'll stop there, and I think we have some time for Q&A.
Yeah, Dr. Thompson, thank you. That was fantastic and very detailed. And we do have quite a few questions. We have about 10 minutes, so maybe I'll give you some of the questions and then succinct answers. The first one, though, is going to be hard. The first question in the queue was how you manage vaccine hesitancy, people that don't want to take vaccines.
Yeah, so that's a hard question, and there's not a simple answer. And you know, I think instead of thinking of it as hesitancy, I think we have to try to put ourselves in the shoes of the individual. Some people refer to it as a lack of vaccine confidence. There are many reasons that people may be distrustful of vaccines. And I think the important thing is to listen and to ask people, why is it that you don't want a vaccine? You know, and you'll hear a myriad of answers, but the more you ask and you listen, I think right there you can gain some confidence from people that you actually care about why they have a lack of confidence in vaccines or they don't want to get another COVID vaccine. And, obviously we're going to go with whatever the person wants, but I think continuing to have those discussions is important. And, to try to debunk some of the misinformation that's out there. No, there are not chips in vaccines that will track you. There's a lot of misinformation. You all know that. I don't have to get into it. But, I always just try to be respectful and try to meet people where they are. But just like smoking cessation, I continue to go back to it. I continue to have those conversations. And honestly, I have had some people quite to surprise me and to say, oh yeah, I'll get vaccinated now. I've been thinking about it. So don't give up, keep being respectful, keep listening.
Excellent. The next question was whether the increased rates of STIs in people with HIV might be related in part to our increased number of visits and screening.
Well, I think there is some thought that maybe we're picking up more. And most of what we pick up are asymptomatic infections. I think there also is a question about the effect of HIV PrEP, so that people who were previously using condoms because they didn't want to get HIV may be using fewer condoms, maybe picking up STIs. Honestly, I think for all of this, it almost doesn't matter, because if we are seeing a lot of STIs in our patients, then we're definitely doing the screening, which we need. Increased screening by itself doesn't necessarily cause STIs. So we hope that increased screening will result in increased rates of negativity. And I will say with DoxyPEP, I have really been very impressed. Patients are coming in for screening. They feel empowered because they are doing something to protect themselves. And I think it has been a very successful intervention. We'll see the extent to which it is decreasing rates of syphilis and chlamydia in particular. Some people have said that it has had an effect on the current rates. Certainly in some areas where it's been studied, like San Francisco, they have seen plummeting rates of STIs. So I think, that is an intervention that has a lot of promise, and we have to keep screening even on DoxyPEP.
Great. And in fact, the next question is about DoxyPEP, and it says, are there data in trans men in terms of the use of DoxyPEP?
Short answer, no. We really don't have as much data as we need in almost anything about DoxyPEP. I think there is the same concern that we have in cisgender females, because that study in Kenya showed no efficacy, but the adherence was really the key to that. So for trans men or cisgender women, there really doesn't seem to be a biological reason that it wouldn't work. And I think that is the discussion that we have, just saying we don't have a lot of data, but here's what we know about this, and continue to screen. I do have trans men who take DoxyPEP.
An important vaccine question. Someone presents for care and has a CD4 count less than 200. Do you delay routine vaccines, or how do you approach that?
Yeah, so I think it's a really good question. And remember that they may not get the most robust response, but many people do get a very good response and a good enough response. So I wouldn't say not to vaccinate. I mean, certainly when you talk about the seasonal vaccines like influenza vaccine, I vaccinate. I vaccinate for COVID. I think For hepatitis A, if you have a person who is not at very high risk for hepatitis A, you may want to defer that until their CD4 count rises. Meningococcal vaccine, if they are not at terribly high risk, you may want to defer that until their CD4 rises. And, you know, I think hepatitis B is a little bit more difficult because we certainly worry about hepatitis B, particularly in people who are going to be going on a 2-drug regimen that doesn't cover hepatitis B. So remember that if you do vaccinate people for hepatitis B and they don't get a good response with a low CD4 count, then you can revaccinate them when their CD4 rises. And that's true with any of the other vaccines.
Well, that leads into another hepatitis B question, that is, do you vaccinate someone that just has a hepatitis B core antibody positive?
Interesting question. So, yeah, so, you know, for some reason, these people were exposed to hepatitis B. They didn't develop an immune response with surface antibody. They do need to be vaccinated. And you can often give one, you can give a full vaccine series. Some people give one vaccine and measure the seroprotective response. But in this case, you want to see a hepatitis B surface antibody of above 100, not 10, because these people probably have had some trouble in the past in terms of mounting immunity. So you want to see a surface antibody titer of greater than 100.
Right, it looks like we have time for one more question. There was a question about prior smallpox vaccination and what that means for your current approach to preventing Mpox.
So there is probably an effect from prior smallpox vaccination. I am vaccinating people who have had prior smallpox vaccination with Mpox vaccine, and remembering to get 2 doses into them, because that's our biggest problem with Mpox vaccination, that people get 1 dose and they think they're covered. It really is not very good coverage from a single dose. Whereas people may well have some protection against Mpox from a prior smallpox vaccine, I would still vaccinate them for Mpox.
Excellent. I think that's I apologize. There were a lot of questions, and it's just hard to get to all of them. And we want to honor people's time. And so I want to thank Dr. Thompson again and the IAS-USA for really putting together this fantastic presentation. A few final slides before we let you go. This slide is information on how to claim CME or pharmacy nursing credits. Feedback is actually very important. Future webinars are really based on the feedback that we receive from these webinars. So please evaluate this presentation today. Just a few upcoming IAS-USA presentations. There will be an update on the new antiretroviral therapy guidelines with Dr. Raj Gandhi. There will be a webinar on gender-affirming hormone care for people with HIV with Dr. Poteet and Radix. And there's a virtual course on the updated guidelines, open to all on December 12th. There's an upcoming webinar on HIV-associated tuberculosis. There's been a lot of change in the guidelines recently with Dr. Benson and Dr. Gandhi. And also to remind people about CROI, registration is open. This is the premier HIV research conference. And so if you are involved in HIV research, education, please consider this conference. And there's a conference on bacteriophages coming up quite a bit in the future, October of 2025. And that's the end, and we're going to let people go. Again, a final thank you to Dr. Thompson, and thank you all for participating. Have a good afternoon.
Everybody.